Every year, Britain hires more doctors from Nigeria than Nigeria's own medical schools can produce in the same amount of time. Think about that. One country trains them, another country takes them, and nothing illegal has happened. This is not a story about one broken hospital. This is a story about the largest talent extraction machine the world has ever built, and how the richest nations on Earth are solving their healthcare crises by importing the solution from countries that can least afford to lose it. To understand how we got here, you need to understand something first. The world has never been better at medicine than now. We can replace organs, sequence genomes, keep people alive who would have died decades ago. And yet, getting sick has never felt more like a gamble, financial, logistical, geographical, because healthcare is no longer just medicine. It is one of the largest economic systems on Earth. Governments spend trillions. Insurers manage risk pools the size of national economies. Pharmaceutical companies develop drugs worth billions. And every single player has an incentive. Governments want better outcomes without unlimited spending. Hospitals need revenue to survive. Insurers need to control what they pay for. Drug companies need profitable markets. Patients want the best treatment they can get, preferably before it is too late. Those interests overlap, they also collide. And healthcare has one feature no other market possesses. When you need it most, you cannot walk away. You can postpone a car, cancel a holiday, live without a new phone. You cannot negotiate with a heart attack. So, why does the richest country on Earth spend over $12,000 per person on healthcare, nearly double Germany, triple the United Kingdom, and still not have enough doctors? Why do countries with universal coverage keep patients waiting for months? And why, in the end, are the nations that need healthcare workers the most precisely the ones losing them the fastest? The answer is not in one broken system. It is in all of them, working together to create a global shortage that nobody wants to claim responsibility for. Let's start with the country where the price of the system is hardest to ignore: America. Imagine waking up one morning with a crushing pain in your chest. You call an ambulance. At the hospital, doctors run tests, take blood, perform scans, and eventually tell you that you need treatment. The immediate danger passes. You are alive. You go home. Then the bills arrive. One comes from the hospital, another comes from the emergency physician, another may come from the radiologist who read your scan. Your insurer pays part of the cost, you pay another part, and suddenly, an event that began as a medical emergency has become an exercise in accounting. Sometimes, in America, you can survive the illness before you understand what it cost you. The scale of the system makes that problem harder to ignore. The United States spends roughly $12,500 per person on healthcare every year, close to 18% of its entire economy. Yet the price of treatment is rarely one simple number. It can depend on the hospital, the insurer, the negotiated rate, whether a doctor is in network, how much of your deductible you have already paid, and what your insurance actually covers. For someone who is sick, none of this feels like economic theory. It feels like paperwork arriving after the crisis, and insurance does not necessarily eliminate that uncertainty. You can have a job, have insurance, and still face premiums, deductibles, co-payments, and co-insurance. Healthcare is not a normal consumer market. If a television is too expensive, you don't buy it. If a restaurant raises its prices, you go somewhere else. But when a doctor tells you that you need an MRI, surgery, chemotherapy, or emergency treatment, your ability to shop around suddenly becomes very limited. You cannot comparison shop your way out of a heart attack. And this is where American healthcare becomes an enormous economic machine. Hospitals negotiate with insurers. Insurers negotiate with hospitals. Pharmaceutical companies negotiate with insurers and pharmacy benefit managers. Employers negotiate insurance contracts for their workers. Government programs pay into the system, while patients move through all of these layers. None of this automatically means the organizations involved are corrupt. Hospitals treat patients. Insurers spread risk. Pharmaceutical companies develop drugs. Employers help finance coverage. The problem is, what happens when every layer adds its own costs, incentives, and negotiations to something people cannot simply choose to live without? When enough layers accumulate, someone eventually pays for every one of them. Employers pay through insurance contributions. Governments pay through public programs. Patients pay through premiums, deductibles, and bills, and households ultimately absorb the cost through taxes, wages, prices, and debt. Insurance can spread the cost of illness, but it cannot make the underlying cost disappear. That creates the paradox at the heart of American healthcare. America has some of the world's most advanced hospitals, doctors, and medical technology. A patient can receive treatment that would have been unimaginable a generation ago and still walk away wondering whether getting better has destroyed their financial future. The problem isn't necessarily that treatment doesn't exist. It's that accessing it can be financially devastating. That is why medical debt became such a powerful symbol of the American healthcare problem. But the economics of American healthcare don't just determine what patients pay. They also influence the people the system produces, where they work, and what kind of medicine they practice. Becoming a doctor in America is expensive, and medical students can graduate carrying hundreds of thousands of dollars in debt. Some specialties offer substantially higher earning potential than primary care, making those financial incentives difficult to ignore. Primary care, the foundation of prevention and the front door of the healthcare system, can become a harder financial choice. The result is a workforce problem. America does not have enough primary care doctors. It does not have enough nurses. And in many rural communities, it does not have enough specialists. So the richest healthcare economy on earth looks beyond its own borders. It recruits from India, the Philippines, Ghana, Pakistan, Egypt, and Nigeria. America imports healthcare workers to fill gaps it cannot fill quickly enough itself. And that brings us to the other side of the equation. But what if the problem isn't the bill? What if you have insurance, you can afford the treatment, and the system still can't get you through the door? That is the uncomfortable reality facing countries that chose a different approach from America. Instead of making access depend heavily on what an individual can afford, publicly funded and universal healthcare systems try to make treatment available to everyone. It sounds like the obvious solution, but healthcare has another currency: time. You can be covered and still wait. You can have a doctor and still struggle to get an appointment. You can know that treatment exists and still spend weeks or months waiting for it. The reason is brutally simple. Healthcare has limits. There are only so many doctors, nurses, operating rooms, and hospital beds. Governments can spend more money, but they cannot instantly create experienced professionals or add more hours to a day. When demand grows faster than capacity, something has to give. Sometimes, it is the waiting list. In Britain, the National Health Service has carried waiting lists of more than 7 million people. Not 7 million uninsured. 7 million covered, entitled, and waiting. Some need cancer care, some need surgery, others are simply waiting to see a specialist. Canada faces a similar problem in specialist care, where patients can wait months for treatment. Japan has near universal coverage, but an aging population is creating another kind of shortage. Nearly 1 in 3 people is already over 65, while the number of caregivers available to support them cannot keep pace. South Korea is aging even faster, with a fertility rate below 0.8 births per woman. China has expanded healthcare coverage to more than 1 billion people, yet major hospitals in cities like Beijing and Shanghai can become overwhelmed as patients travel long distances, seeking specialists and equipment unavailable closer to home. These are very different systems, but they reveal the same uncomfortable truth. No healthcare system can spend its way out of scarcity overnight. One country makes you worry about the price, another makes you worry about the wait, another gives you coverage but struggles to put enough doctors where patients actually need them. And when the math gets tight, countries look outward. They recruit from abroad. They fast-track visas. They offer salaries that attract workers from countries that train them but cannot afford to keep them. The waiting room, then, is more than a symptom of domestic healthcare shortages. It is a recruitment poster for global extraction. Now look at the force that makes all of this permanent. In 2019, roughly 1 in 11 people on Earth was 65 or older. By 2050, the United Nations expects that to be 1 in 6. The number of people aged 80 and above is expected to nearly triple. That sounds like a demographic statistic. For healthcare, it is something much bigger, because an older population does not simply mean more doctor visits. It means more people living with conditions that require care over years, sometimes decades. Hypertension, diabetes, heart disease, dementia, arthritis, cancer, illnesses that do not disappear after one appointment. Modern medicine has become remarkably good at keeping people alive, but keeping someone alive for another 20 or 30 years can require an enormous amount of care. Look at Japan. It is already one of the world's oldest societies. South Korea is aging even faster. Across Europe, populations are getting older, while several countries are also shrinking. China is now confronting the consequences of decades of declining birth rates, and this transition won't stay inside wealthy countries. By 2050, the World Health Organization expects around 80% of the world's older people to live in low and middle-income countries. Now look at the other side of the equation. Families are having fewer children. Working-age populations are shrinking. There are fewer younger adults available to care for aging parents, pay taxes into public systems, or enter professions like nursing and elder care. So the pressure moves in two directions at once. More people need healthcare, and the pool of people available to provide it isn't necessarily growing with them. Imagine a hospital 20 years from now. It has better technology, better drugs, better diagnostic tools, perhaps even artificial intelligence, helping doctors make informed decisions. But if the number of patients rises faster than the number of nurses, doctors, and care workers, technology can only take you so far. Because eventually, someone still has to stand beside the bed. And that is the problem the aging world is beginning to discover. We are getting better at keeping people alive, but we may not be preparing enough people to care for them, which means the shortage is not temporary. It is structural, it is demographic, it is permanent. And permanent shortages do not solve themselves. They get solved the same way, everywhere, by the countries that can afford to pay for someone else's solution. But there is a question hidden inside that solution. Who paid to create the worker in the first place? The university that trained them, the teaching hospital that provided years of clinical training, the public institutions and taxpayers that helped finance the system that produced them. Then another country offers better pay, better working conditions, or better opportunities, and the doctor leaves. Nothing illegal happens. The worker chooses freely. The hospital fills a vacancy. The richer country gets an experienced professional without having to train that person from scratch. But the country that helped produce that professional is left with one fewer doctor. Nigeria is one of the clearest examples. According to Nigeria's Federal Ministry of Health, 4,193 doctors and dentists left the country in 2024 alone. Approximately 66% went to the United Kingdom. At the same time, Nigeria had just 2.9 doctors per 10,000 people, compared with the WHO benchmark of 17. And this is the part the global healthcare debate often misses. A country can build hospitals, it can buy scanners, it can expand medical schools. But if the people trained to run the system keep moving toward whoever can offer more, the shortage does not disappear. It moves. You can build a hospital in 3 years. You can install a scanner in a week. But you cannot manufacture an experienced doctor overnight. And somewhere in the country left behind, a clinic stays understaffed, a ward gets stretched thinner, and a patient waits for a doctor who is already building a future somewhere richer.